chat box and all of you should answer in the chat box. Fine, I'll keep seeing my chat boxes and we'll start. No problem. Okay. So it's going to be around a 35 to 40 minute session. Let me start. Okay. So X-rays in OBGY and HSG. The main focus will be on HSG because that is surely always your table viva and you are going to get for sure. X-rays, as we know, has got very little relevance. Where do we have the relevance? We will just see that also. So basically what happens is that if you look at from the exam point of view, this comes as a spot, a table viva. It's mostly a discussion starter. Like the examiner would want to get your opinion on the X-ray, and then of course what will be the further management, whatever differential diagnosis, that is what you need to keep in mind. So it's most of the time beginning of a discussion, how to read, diagnose, describe will give you, and with examples will be telling you. Okay, so how X-ray is relevant in OBGYN practice today, we'll see that. Of course, there's a risk of radiation during pregnancy, so during pregnancy is almost no, unless it's an emergency. And HSG, the technique, reading, as well as the interpretation, what we'll be looking at. Okay, so just a thing, when we look at the gynecological complaints, today all of us know that ultrasonography is the gold standard, and if required, we may go for MRI, CT scan. So plain X-ray almost not relevant over here. Okay, when are they relevant? In case of a missing IUD or a foreign body, or if there's a post-operative distension. Okay, of course, interventional radiology embolization procedures are very much relevant, but that is for a completely different set of topics. And what are the X-rays helpful to us for is mainly the HSG and occasionally a pelvimetry. Some old-timer examiners, we don't do pelvimetry X-rays, but examiner may ask you. That's why I also got one X-ray with that also, where they may show you the pelvimetry X-ray. Okay, so first let me just see how, let me just explain all of you how do we start the description. So whenever I have got an X-ray plate in front of us, you will say whether is this a plain X-ray or a special. So it's a plain X-ray, abdomen, pelvis, AP view, we can say, or chest X-ray, PA view, or is it a special? By special, I mean, is it a HSG or a IVP or a cystogram or a pelvimetry, etc. Okay, which part of the body are we seeing? Is it only pelvis or is it abdomen plus pelvis? That we should say. AP view, lateral view, oblique view, centralized or not. Okay, so this we remember, this was our MBBS days, our professors to teach us. So that is, you need to remember it even now. Okay, centralized, well centralized or not centralized, exposure is adequate or is it overexposed or it is underexposed. Then you describe the main feature of the X-ray. Directly go on the main feature, what you are seeing, and then the differential diagnosis, if you have any, and the most likely pathology. So this, keep these points in mind. All of you will keep these points in mind. Okay. Yes. Now, why do we require the HSG? So first, because X-ray has got very limited role, I've kept the X-rays for the later part. We are going to discuss first more on the HSG. Okay, so we'll discuss on the HSG first, and then the last 5-10 minutes we can go on to the X-ray, because HSG is definitely going to be asked to you. So about 10% of the couples presenting with infertility will have a tubal or a uterine factor. A clue of this may emerge from the history. You have got a PID or a tuberculosis. Examination, if we have a fornitional tenderness, fullness, uterine deviation, enlarged uterus. Ultrasonography may give us an idea regarding hydrosalpinx, submucous fibroids, and polyps. So this you need to keep in mind definitely, because they're going to be hampering the fertility. Okay. So to assess the uterus and the tubes, what are the options? So the main thing is a HSG, which is our hysterosalpingography. We also have got sonography, in which we infuse saline. So that would be called as saline. Okay. So it is called as SIS. What is SIS? Anybody? Saline infusion sonography, or also called as sonosalpingography. Okay, where we sonosalpingography. Okay, is it visible to all? I think the annotation, yes. Okay, so we push in a saline mixed with some air bubbles, and then we do a ultrasonography and see. Okay, and of course laparoscopy is the gold standards combined with hysteroscopy wherever required. So out of this, HSG and laparoscopy are the most popular. HSG, always remember, is the initial. We should never in our exam say laparoscopy first. Laparoscopy is of course the gold standard, but that is reserved when more of a see and treat approach. So the initial investigation we prefer is always HSG, and laparoscopy we do it if we find some abnormality in HSG. So just a comparative study, meta-analysis of 20 studies, HSG has a sensitivity of 0.65, and so I don't expect you to remember these numbers, but if HSG suggests obstruction, that means the tubes are blocked, it is confirmed by laparoscopy in 38% of the cases only. Okay, but if HSG shows the patent tubes, then the laparoscopy will confirm the same thing in 94% cases. So that is a good number to remember, that if HSG is okay, we are going to almost find out that the tubes are patent. But other way around, if HSG is showing block, then obstruction could be there only in 40%. Okay, and of course the abnormal HSG should always be confirmed by doing a laparoscopy. Okay, so this is a quick description of the things where the gold standard confirmatory is laparoscopy, but HSG remains the first line. Detailed information we'll get about the peritubal adhesions. External surface of the uterus can be assessed to distinguish between bicornuate and septate. I'll also show you the HSG for uterine anomalies, where you know that HSG is not 100% accurate. Okay, of course, the laparoscopy, we get additional diagnostic information such as biopsy can be performed, or some adhesive chocolate cyst can be tackled at the same sitting. There is no other diagnostic yield. Can be used as a see and treat approach. No therapeutic role, except sometimes flushing out of the tubal debris as known to increase the pregnancy rates. And pain is significant. Here we do it under anesthesia, so there's no pain. But of course, what are the disadvantages? It is not possible to diagnose intrauterine pathology unless you're going to combine it with hysteroscopy. Of course, it is an invasive testing, so anesthesia, risk of anesthetic complications, yes, injury to bowel, bladder, vessel injuries, which are very, very rare over here. Diagnosis of intrauterine pathology possible, minimal invasive, very rarely anaphylaxis, no anesthesia, no hospital stay, of course less expensive, and laparoscopic cost is higher, and even though a day care or few hours, but it requires hospitalization. Okay, so now, however, some cases we may directly want to perform laparoscopy if there's any history suggestive of any pelvic surgery, PID, appendicitis repeating episodes, pelvic pathology already seen on examination, and USG. Okay, findings are confirmatory, then you may directly want to proceed with a histolaparoscopy. Okay, so now, can anybody, of course, very basic, but on which day of the menstrual cycle in the chat box, anybody, when do we perform the HSG? What is the best time to perform the HSG? Yes, all of you. Yes, day 7. Yeah. So day 5 would be earliest. All of you very good. Yeah, 7 to 9, perfect. 9 to day. Yeah. So generally, yeah, excellent. Okay. So if the patient needs for 4-5 days, day 8, day 9, day 10 tak hum kar sakte hain. So yes, generally we do it on day 8 or day 9 of the cycle, up to 10 days definitely. Yes, avoid it over too close to ovulation. Okay. So you need to review the previous reports. Within 10 days of the menstrual cycle, let the bleeding get over. Antibiotics we generally give. Cervix is cannulated, and oral analgesia may be given. Atropine we should definitely give, and antispasmodic can be given. Okay. Just a second, all of you. Just 1 second. Okay. Yeah. Is it all okay? Yeah. So Yes. Okay. So what is the principle of HSG? We inject a dye into the uterine cavity and then take an X-ray. Yeah. Okay. So we take a HA, we inject a dye into the uterine cavity and then take an X-ray of the pelvis simultaneously. Ideally done under a fluoroscopy guidance, and a dynamic view of the uterine cavity and tubes gets delineated. Okay. Mainly, always, all of you can see this, which is this instrument. This is the Leach Wilkinson cannula, also called as the Colvin's cannula. Okay, so this is what we see. You will have to identify this in your exam. You'll be able to see, I appreciate, can all of you see the serrations. Okay, so you'll have to say that this is an HSG performed with a Colvin's cannula. Of course, various catheters today are available, and balloons are also available, and HSG catheters are available also. Okay, now this sometimes they may ask you that what are the mainly the dyes which we use. So we have got a oil based contrast, okay, which is called as the lipidiol, which is the new thing in, and we have got a water based ionic contrast, and sometimes even water based non-ionic contrast. Okay, so the slow injection takes minutes to pass through the uterus. A delayed plate after 24 hours may be needed. Significant pain, anaphylaxis, granuloma formation, but it is cheap, and flushing out effects and seen enhanced pregnancy rate. So that's the advantage of the oil-based. The Conray is absolutely a fast procedure. That's what we normally prefer. Anaphylaxis is very, very rare. Pain may be there or reduced, and flushing out is less marked. No more pregnancy rates. But non-ionic dyes are more expensive than the ionic contrast. Okay, so this they might ask you oil-based and water-based. Okay, so now let us, and we take the contrast, load it, do a per speculum examination, see the cervix, cannulate it, and then try to push in very little amount of dye. Make sure there's no air bubble, and then at least 4 films, minimum 2 to things, and 2 to 4 films you may take. Okay, so now this is what all of you will by heart this from now only, and please keep it when you are giving it in your exam. Okay, when you are saying the in your viva, all of you will by heart this. So this is a HSG plate done with which cannula? Is it a Leach Wilkinson, Colvin's cannula, or Rubin's cannula? Then focus on the, see, directly the mistake students make, we directly go to the tubes. No, remember it is HSG. Hystero pehle aata hai. So you are supposed to comment. We are doing it for tubal patency, but lots of information about the uterus cavity, shape, filling defects, all that you will come to know, okay, including the shape of the uterus. So always don't directly comment on the tubes. Okay, sir, I can see the tubes are patent. No, we'll have to say the uterus first, number of cavity, size of the uterus, shape, triangle, regular cavity, 2 cavities, 1 cavity, triangular shape, any other shapes we will show you, margin, smooth, any other or irregular margins, and of course any filling defects. And then the tubes, extent of the tube, whole length of the tube is thin, proximal tube is thin, distal tube is thin, whether the spill is free, and if any block or dilatation, and any other things if we notice it. Okay, so and at least first early filling phase, you can see the dye just entering the uterus. Then this is the cavity which I'm reading in the uterus. All of us can see the tubes also if you zoom in, and then of course we see the spill of the dye. Okay, so that is what it is. So can anybody would want to take this first HSG? Which cannula? Done with which cannula? HSG done with what? Chat box. Yes, very good. Leach Wilkinson or Colvin's cannula, very good. Go on to the next part. Then what do you see? Very good, agreed. So it is a, you can see how you can see this is which instrument, all of you? This is which instrument, other instrument here, which I'm marking now. So this is a Valsalem, okay, which is very important. I'll tell you why. Because if Valsalem we have not used it, the shape will get, you might not get a perfect, okay. So this is our Valsalem, and this is perfectly, all of you can see the serrations like this. So this is our Colvin's or LW, okay. Now, anybody, what do you think? Yes, so this looks this is a normal HSG, which I had shown you to begin with. Okay, so you can see over here, this is the uterus. This part is the fallopian tube all the way up to the thin, nice, bouncy, wavy tubes, and all of us, lots of free spill we can see. So absolutely correct, all of you. All those who have said this is a fairly normal or a normal HSG done with a Colvin's cannula. Yes, very good. So that's how what I did. So no filling defect, triangular cavity, both fallopian tubes well delineated with the up to the femoral end, and then also the spill of the dye is visible. So that is how you identify. Absolutely correct, all of you. Yes. Now moving on to the next slide. Just a second. Sometimes this is getting stuck. Yeah. Okay. Now this is also the normal HSG. One more image. Okay. Nice triangle cavity, no filling defect. You can see the fallopian tube right up to the end, and then we see the free spill of the dye. Okay. Is it clear to all of you? So this was one more. This is again a normal HSG, as we would call it. Okay. Now we start. So HSG plate, instrument, which instrument? Uterus, how is it? Tubes, how is it? Any other calcification do you see? And this. Now, all of you, can you identify this? What is this? Why is the shape like this? Why is this a normal? The one in the right corner. Okay. So this is because the uterus. Okay. Always you apply the Valsalem and pull it towards you. Yes, it is slightly painful, but actually this is also a normal only. But because there was what we called, we had not applied a pull of the Valsalem, it is coming like a deviated or a ulta uterus lag raha hai, but actually the uterus is same only. Okay, so if had a traction been given, there would have been no problem with this. Okay. And similarly, this also, yes, acutely antiviral. This also, this is a deviated, but this is probably because the Valsalem traction was not applied. If we applied, we would have got the proper image like the one which you get over here. So all these are variations in normal. Yes. Now, can anybody tell me what is seen over here? Yes, all of you. Take your time. I think all of you can see this. Again, HSG with the Colvin's cannula. What do you see? Tubal block say better. More than that. Okay. Forget comment. See, arcuate uterus, septum से ज़्यादा. Okay. Block नहीं है. Yes. Where? What is this? Yes? It's a solitary filling defect. Okay, is it clear to all of you? So there is, you are supposed to say right now only, we cannot say polyp hai, what it is. Okay, so according to me, if you see, yes, I agree with you that thoda sa uterus is looking arcuate, but more than that, okay, arcuate, subseptate, difficult to say. Yes, I agree with you, there is a fundal indentation, but more focus, and I don't think it's a block because I can see the dye and I can see the spill over here. So I wouldn't say as a femoral block or a tubal block, but the most striking abnormality. So then what could be the differential, anybody? What could be the differential? My focus is this. This is a solitary, you say a solitary filling defect. Yes, so absolutely correct. It could be a polyp, it could be a fibroid, it could also be a hair bubble. Okay, if you haven't, that's why you need to de-air. Okay, so all of you correct. Fibroid ho sakta hai, पॉलिप हो सकता है, एंड एयर बबल भी हो सकता है. Obviously, you need to see whether it passes or not. And of course, then you might want to, depending on the history, you might want to do a hysteroscopy and get the polyp out or this. Okay. Yes. So very good, all of you. So this is, remember, this is solitary filling defect. So I would say it in my exam, this is the HSG done with a Colvin's cannula showing a single uterine cavity. It is, however, not well opacified. There is a solitary filling defect. However, tubes both right and left can be seen up to the femoral end with a free spill of dye. Okay, so solitary filling defect due to whatever, and then you give your differential diagnosis. Yes. Now here, what is obvious abnormal? The shape of the uterus. Yes. Anyone else? Very good, Ishira. Anyone else? Yes. So this is, if you, yes, very good. So this is clearly a T-shaped uterus, as we would call it. Okay. Various reasons for that are there, but definitely this is, you can see it, that the normal uterus should have been, yes, so it is T-shaped, could be adhesions. See this much part. Okay. So this, ये जो हम draw कर रहे हैं, इतना triangle तो होना चाहिए था. So all these parts, definitely this. Okay. So anyway, we don't see this, but which drug was causing this? If I ask you, now we don't, because this drug was stopped long ago. Yes, very good, Monica. Excellent. DS, very good. All of you, Swati, Rohini, Nirmala, Kanchan, all of you, excellent. Superb. Yes. So this is textbook mention is a DS uterus, but nowadays DS was stopped long ago, long ago. I think if you see the history, DS was stopped almost in 1970 के पहले ही stop हो गया था. So now we'll not be seeing babies born with this. Okay. So DS exposure kind of uterus, yes, but now that so you can say it's the cavity, the tubes are okay, but the cavity is not complete triangular, and it looks like a T-shaped uterine cavity. It could be because of adhesions, tuberculosis, or even just a variation in the shape. And what is the T-shaped uterus known to cause? Anybody? Which kind of a problem is T-shaped uterus known to cause? Yes, we can have lots of complications, abortions, miscarriage, preterm, infertility, and the surgery is again you need to go, yes, RPL, very good, Shreya. It is known to cause recurrent abortions. But of course, all T-shaped you don't operate. If there's a history of it, then you definitely need to go and do a hysteroscopic lateral plasty. Filling defect, thoda sa, probably Ishita, this what you are talking about. Not too sure. Yes, could be just the initial phase. If we put in more dye, it might get opacified or thoda sa exposure का भी issue हो सकता है. But main, this is for the what you called, or this would also be the air bubble. But main, this is to show the shape. Okay. Yes. Now what is this? All of you, or this? So again, Colvin's cannula. Yes. So only one horn. So it could be, yes, very good, banana shaped, as you say, retort shape. So this is our unicornuate most of the time. Very good. Unicornuate most of the time. Or it could also be, very rarely, as you can see, that it is a unicornuate most of the time. Yes, correct. Aditya Nimbarkar, correct. So it could also be, that was coming to that it could be one horn of a bicornuate with a non-communicating. You say the obvious things first, and uterus diadelpheus, where only one side is cannulated. Okay, but then you would see two cervixes when you do a P per speculum. Okay, if it's a complete diadelphus, we'll see. Okay, where, so correct. So uterine diadelphus, where one side is only communicated, is there, and also it could be lots of adhesions on one side. Okay, so that means what, all of you, that suppose, just to show you, let's suppose if this is the cavity, I'll show you the picture also, and suppose lots of all these sides where adhesions are there, all these sides adhesions are there, Then when I put the dye, then only this side of the uterus would get opacified. Okay, so yes, so like a partial Asherman, not a complete Asherman, but this. Okay, so that is also the possibility. Very good. But mainly say the four common things first. So yes, unicornuate and also a diadal face by one caliber. Yes. Yes. Now what is it? Chalo. We all can see of this, which is what? Let us first look at this one. This one. Yes, always. So always remember that you have a, it's not a, ha, so no. So how can you make out between septate and bicornuate? Anybody? Septate versus bicornuate. हाँ, very good angle. So कोई बता देगा angle के बारे में कितना excellent. So this, please understand that one is a fusion defect, one is a resorption. Septum is the okay. So yes, absolutely correct. Nips is the one. So if I just draw and do I get just a second again? There's a slight. Yeah, I just need the that's got has got stuck slightly. I'm not able to move forward smoothly. Just give me a minute. Yeah. So all of you pay attention that all of us know that when there is a septate, very sorry students, this technical glitches sometimes can get the better of us. 1 second, the PPT is not moving forward. Yeah. So we know that if this is the uterus, the septum is going to be something like this. Yes or no? So septum is going to be like this. This is our septate uterus. So when I will push the die, what is it going to get? We are going to get two horns. We are going to get something like this. But definitely what will be the angle? It is going to be a acute angle. Of course, the gold standard is hysterolaparoscopy when we confirm it, but an acute angle is going to give me a impression it is a septate uterus. Okay, whereas bicornuate, the two horns are going to be wide apart, and therefore this angle is going to be a obtuse angle. Is this understood to all of you? So this could be, not this could be, this will be our bicornuate uterus. Okay. uh, yes, so that is how you get it. Okay. Yeah, so yeah, can all of you see the screen? But I'm not able to move it. Yeah. Yes, but I am not able to. The PPT is not moving ahead. Just a second, all of you. Yeah. Yeah, okay. Sorry, students. Sorry for that technical glitch. The PPT had got hanged and I had to restart the computer. Yes. So we were on this HSG where we were discussing about the two cavities. And as I explained to all of you that if we are having a acute angle, we would go in favor of a septate. And if we are having a big wide angle, obtuse angle, we would go it in favor of all this we did, right? We had discussed all this. I want all of you to come. Yes. So this, according to me, please keep this in mind that if the angle is a septate less than 75, it would be a acute angle. Then okay, if it is a acute angle, then we would call it as a septate uterus. It will go in more in favor of a septum. And if it is a wide angle, wide horn, then it would go in favor of a yes. Okay, so the first HSG what we can see over here is a septate uterus, I would say, and this is a bicornuate uterus. Okay, so that is what it is. Now moving ahead. Uh, Very sorry, students. This has never happened before. Been taking lectures online, but this is really not working. I'm not too sure what's wrong with the system. Just give me. So let's move ahead. I hope when I start the okay. So this we know, we can see the two horns, and we know that this is a septate uterus. I would label this. I would label the first one as a septate uterus, and I would label the this one I would label it as septate. This I would label it as bicornuate. Okay. Now we also have this clearly separate two cavities. Okay. So this is a double uterine cavity. Again, we have to see on per speculum whether it is two cervices or not, and then you need to take a call. Okay, or then you need to make a call. Okay, now we also just let me try. Yes. Okay. So anybody, what are these types? Again, this is a filling defect as we have already shown to you. The first one is a solitary filling defect, and this is obviously a huge filling defect. So it's the kind of X-rays which could they ask you. So what are the filling defects, artifacts, air bubbles, adhesions, sometimes even a gestational sac. Okay. Now, okay. Can anybody tell me this over here? What is it? Yes, of course, it's labeled as the bilateral tubal block. Why the tubal blocks could be, we have got a proximal block over here, or we could also get a, all the way the fimbrial, you can see the tube is seen all the way over here, and then there is a terminal hydrosalpinx and there is no spill of the dye. So this is also a block tube, and this again only the triangle part is seen. We have got a proximal block. Okay. Now, anybody would want to label this as a bilateral tubal block. Okay. The differential is also a spasm because only the uterus is seen, and I need to confirm this with a hysterolaparoscopy. So again, you will identify, I will say that this is HSG done with a Colvin's cannula. Only the uterus is seen, tubes are not being seen, and therefore it's a bilateral tubal block or a spasm. Okay. Now, anybody with this in the chat box? What is very obvious? Excellent, all of you. Excellent. So rather than saying Asherman directly, all of you will say, sir, multiple filling defects. Okay. Multiple filling defects. That is what you need to keep in mind. It is multiple filling defects. Very good. Most likely to be multiple filling defects. Most likely to be Asherman syndrome. I agree with all of you. Very good. Now, anybody, again, this one. So all my, okay. Again, HSG done with a Colvin's cannula. Always look at the side. What is this? Yes, not infantile. So very well. Uterus is very well. Yes, perfectly correct. It is, you will say, it's a left tube normal. All of you see I'm highlighting it. This is the tube all the way up to here. This is a very good spill. So the left tube is absolutely normal, but the right tube, all of you, we are not able to see it at all. So it's a right cornual block, right tube block. Very good, all of you. Okay, this again. Okay, so again, depending on the free spill or occurred spill, and you may also have hydrosalpinx. Okay, just a couple of things just to show you the classical images. This is in tuberculosis. You can see some small filling defects, could be adhesions, and this is called as a typical lead pipe tubes. Okay, lead pipe tubes. Again, there's no spill. There's no spill. Okay, and this is our hydro again. So cavity is okay, and both the tubes are distended with the material dye, and that's the hydrosalpinx, or we also call it the golf club tube. These are all the descriptions which you get in genital tuberculosis. Okay, yes, this again, if you see the half of the uterus, instead of normal being triangle, there are all the adhesions over here. So it's very difficult to say, but again, this is a hydrosalpinx over here, this is a hydrosalpinx. So all these are very classical findings which you get in your genital tuberculosis. Okay, and of course we should also know the intraversation of the dye, which could be a feature. Okay, so these are all the features which can, you are supposed to, this books give us all of, you know, this the filling defects, intraversation, lead pipe tubes, golf club tube, okay, retort, tobacco pouch, all that, hydrosalpines, loculated spill. Okay, now anybody with this X-ray. So last thing, so we have finished off with the HSG. Just some 2-3 X-rays. What is this? Show you. Yeah. So, Dr. Monica, you may not say, how will you say it is misplaced or not? What will you require? It's just an X-ray abdomen and X-ray pelvis with a IUD, copper T, most likely copper T 380. You can see the 380 ka shape. Can we say it is misplaced or not? Yes, Monica. So is the sound over here? No, sound is not here. So you cannot say whether this is a misplaced or not. You require sound. Of course, ultrasonography gives you the diagnosis, but if you have to use X-ray, you need to sound the uterus. Okay. So yes. So when you take another view with the sound, that is when. Now, can you see this first one is the older one, your Lippes loop, and this is the one which tells you that whether the IUD is inside or outside. So when you sound it with it, okay. So when you have sounded the uterus, then you know it's a sound is in this place. So then the copper T is outside. Okay. Is it clear to all of you? Yes. Now, can anybody tell me this? What is this? Foreign body. Okay. What is it looking like? What is it looking like? Okay, so the previous one was correct, the sound, and that this one, this is what. Okay, so this is your, again, very rarely these are not going to be shown to you, so don't worry, but this is the tooth calcification. If they give you the history, this is, yes, multiple calcifications, but if I tell you this is a tooth, so this is a dermoid cyst. Okay, gynac patient dermoid cyst. They'll of course give you the history. Very don't worry, these X-rays are not going to be kept a part of it, but as just as a, sometimes if an old timer examiner wants to ask you this. Okay, now anybody very difficult, but can, what is this thing over here? Yes, Monica, excellent. This is a spring coil. All of you, Rashmi, Isha, very good. So this is Assure coil. Okay, Assure as a method of contraception. Okay, just wanted to show you something out of interest. Okay, we know whether calcification could be a foreign body, is it a IUD, teratoma, lymph nodes, bladder calculation, or even calcification than this one. Okay, what is this? Multiple air fluids level obstruction. What is the common cause? If the is gas under the diaphragm always abnormal? No. What is the common cause of gas under the diaphragm? Yes, absolutely correct. Laparoscopy surgery, laparotomy surgery, all that will come to know whether this is there. Okay. Last thing, pregnancy X-ray we don't do, but in case if they ask you, then again X-ray of the pelvis or the abdomen, well centralized, adequate exposure, number of fetus is what you see, and a specific part. Okay, so this is just a normal, okay, well flexed baby with the flexion, okay, attitude of flexion. Okay, now this anybody can tell me what is this typically? So which presentation? Can anybody tell me about the presentation? Yes, very good, all of you, excellent. Let's say this is breech because we are seeing the baby head in the fetal skull. And what is it? Yes, so this is the stargazing as that breech with extended. Very good. Okay, so as the all of you know, stargazing fetus, or also called as the flying fetus. Okay, breach, and there could be some cervical pathology, could be a cystic hygroma, goiter, whatever. Okay, but stargazing fetus. Okay, and the last slide. This is the X-ray pelvimetry, very rarely done, which view exposure number of fetuses, which is the diameter which is marked over here. You can see this and you can see this. These are what? So you can see this part coming here. Yes, very good. So what is it? And it's given to you 8.8. तो क्या लग रहा है? All of you. Yes, so definitely it is the BPD. All of us know 9.5, so 8.8 will not negotiate. It is the bispinous diameter or the interspinous distance. Definitely yes, all of you correct, and it is inadequate. It would lead to a DTA, or it will not. It will be a mid pelvic contracture, and we would like to do LSCS. Okay, so these are all the things. Yes, contracted pelvis, standard pelvis could be yes, interspinous distance is narrow. Okay, so mainly yes, that is what is our presentation all about. I thank all these teachers and occupational specifically for sharing the access. Some of them are my own collections, and all these teachers, Tulnada sir, Amaya sir, Samir sir, and Kunal, but given us some of the contributions. I hope all of you had a great time today. It's a very scoring subject. I love doing HSGs. Even today, I do HSGs myself. I don't leave it to the radio technician. I go for all my infertile patients. I go to the X-ray laboratory, X-ray center, and I do the HSGs myself. And I love doing HSG and I love reading HSGs and lots of other information, including even cervical incompetence, all that can be diagnosed with HSGs also. So I thank Dr. Sanket for having me over here.